Dear colleagues, ladies and gentlemen, good evening, everybody. I'm Lina Pascu. I'm Assistant Professor of Endocrinology at the University of Athens in Greece. Today is a special day. It is the first World Hormone Day, so we have a special reason to celebrate. This is a special day, and we are all responsible, and we have the opportunity to raise awareness around the globe to scientific societies and to communities and people about hormones and how hormones matter. So it's a special day, and we really hope that we will celebrate this day every year on 24th of April. For ESE Spotlight on Science is also a special day because today we collaborate with a very important scientific society, the European Neuroendocrine Association. And the topic of this webinar, of today's webinar, is how hormones can be potential tools in precision medicine. We have the great honor and sincere pleasure to have with us Professor Manel Puig Domingo. He's an amazing professor of endocrinology and scientist. Please allow me to say a few words about Professor Puig Domingo. He's currently head of professor and head of endocrinology and nutrition at the University Hospital German Trias in Barcelona, Spain. He's also the former director of the relevant research institute. Manel is professor of endocrinology at the Autonomous University of Barcelona also. He has served as the representative of the European Society of Endocrinology to the European Agency of Medicines and was member of the ESE Clinical Committee. He was previously been the president of the Spanish Society of Endocrinology and Nutrition and visiting professor at UCLA Cedars-Sinai Medical Center. Main research interests are pituitary, thyroid disorders, and diabetes mellitus. Today, Professor Puig Domingo will talk about somatostatin receptors in pituitary adenomas and how they can tailor therapy. So we are really glad to have you, Professor, and we look forward to your lecture.
Hello, thank you very much, Lina, for your kind introductory words. I am really very honored and pleased to be here to celebrate the Hormone Day. So, as Lina said, I am a clinician, but I am also a clinical scientist. So I will talk today to you regarding a very long way issue, which is the history of the somatostatin receptor in pituitary adenomas. And as a matter of fact, trying to be a little more focused, I will exemplify how do we have been exploring and traveling through this passionate way, which has been the application of somatostatin receptor to tailor therapy, particularly in acromegaly patients. So these are my disclosures. And as you might know, the somatostatin receptor family is a family of different receptors which are characterized by being the classical transmembrane receptor with an extracellular domain and an intracellular domain, where in the extracellular domain, somatostatin, either the 14 amino acid or the 28 amino acid isoform are able to connect. And then after the connection, the interaction of the ligand, in this case, somatostatin molecule with the receptor, some different biological consequences arise, mostly through the interaction of the internal intracellular domain of the receptor with the G protein. So the somatostatin receptors are, in this regard, classical G protein coupled receptors. This family of receptors mostly is composed by 5 different isoforms, which are depicted in this slide. And it is very relevant not just how these receptors behave themselves, but also what is happening after the interaction of the ligand with the receptors within the intercellular domain, meaning that what is happening after this interaction of the ligand with the receptor is as relevant as what itself happens, but not just with the interaction but within the cell. Just to remind you that these receptors are quite dynamic. They can heterodimerize and have some cooperative function between them, and not just between the somatostatin receptors themselves, but also with other receptors which matter for pituitary cells and particularly for pituitary adenomas, mostly regarding the dopamine receptors. You might remember that many years ago, some lines of pharmacotherapeutic research tried to design some molecules, chimeric molecules that were able to contact to make biological connections with either the dopamine as well as the somatostatin receptors. Mostly the action which arises after the connection of the ligand with the receptors is having very important biological actions, and the most prominent of them in the first years of discovery were not just those devoted to control hormone secretion, but also the profound actions on cell proliferations, mostly through apoptosis or through direct cell proliferation control of the cell cycle. And for doing this, the different receptors have specific pathways, some of them with quite known signaling molecules known in different biological systems, but which include protein kinases 3 alpha, RAF kinase, protein pyrophosphatases, and MEK kinases. Most of the actions are also including inhibitory actions on adenylyl cyclase, which is something relatively common for every of the different receptors of the family. One of the issues which has been very much interesting, not just for endocrine tumors, but also for oncology in general, has been, as I said, the actions on antiproliferative and angiogenesis. In beside the control of cell cycle, growth factors, and promotion of pro-apoptotic effects, which could be considered as direct antiproliferative effects. Other indirect antiproliferative effects are also seen when somatostatin interacts with the family of the receptors. And one of the most prevalent or most important actions is upon the angiogenesis way. In this action is very relevant. It has a very important potential or therapeutic potential in oncology in general, as also as endocrinologists we know when we are treating not just pituitary tumors, but neuroendocrine pancreatic tumors. And it accounts for the quick response we might see in some of our patients presenting with a very important tumor burden. As you can see in this picture of this magnetic resonance of a patient which we just saw 2 weeks ago in our hospital. You can see here an enormous gigantinomac pituitary adenoma. In this case, it is a mixed GH prolactin circulating tumor. In the combination of different treatments, and particularly with somatostatin receptor ligands, might account for a relatively rapid decrease of tumor volume. This used to be seen in about 30% of cases with a decrease in volume from basal volume of about 30%. And probably most of the action is performing this way through control of angiogenesis of the tumor. Not just this, also, as I said, activation of pro-apoptotic ways, but angiogenetic targeting is probably one of the most important for alleviating this tumor burden in our patients. The different family of receptors account for, under the endocrinological point of view, different specific actions. And some of them are particularly, for example, regarding somatostatin receptor 3, which I will give you some additional information in the slides to come. But also quite interesting is that in pituitary tumors, in general, not just in acromegaly, somatostatin receptor 4, which from a biological point of view centers its action when occupied by the ligand regarding cell proliferation control, it's virtually very difficult to be found in the tumors where what we're seeing in our clinics. While most of the relevant somatostatin receptor, which we have been working in the clinics and in research, are mostly receptor 2 and receptor 5, as you might know, regarding the drugs we have been available till now. Focusing on acromegaly, which has been a topic in which I have been working for more than 20 years, and in the last 15 years in the research area, you might know that currently recommendations for medical treatments indicate that we initially have to try somatostatin receptor ligands for treating our patients. However, as you will see in the next slide, we are having some problems because as much new treatments, new family drugs we are having, the decision on how to use one or another of the drugs is becoming more and more complicated. And this is where the issue of precision medicine is coming, and will be, for those of the audience that are young, either researcher or clinician, should be the way to treat our patients. Why this is so? Because we know that having different compounds that would be useful for our patients, our mission is to identify which will be the one of the compounds which will be the most feasibly beneficial for our patients. And we need tools for identifying this responsive at the different treatments we are having, in order not to lose time trying to see in the way of assay error spirit how we will identify these compounds. And as you know, not just this family of about 3 or 4 compounds targeting somatostatin receptor ligands are now accessible to the clinics, but in the relatively near future, as you can see here, we will be having more compounds, meaning that the difficulty for decision what will be the one more feasibly interesting for one patient, for a given patient, will be an effort which requires biomarkers identifying the response to these treatments. As for the compounds that we are currently having, you know that octreotide and lanreotide, which are considered first-generation receptor ligands, have a different affinity and could be considered as virtually mono-target to somatostatin receptor 2, while the new or second-generation somatostatin receptor ligand, which is pasireotide, is having a multi-target effect, because it's not just targets somatostatin receptor 2, but also receptor 5s, and probably, as you will see, the potential to interact with receptor 3 is also very important. So pasireotide is able to connect with somatostatin receptor 2, 5, as well as 3. And this has, as a consequence, a decreation or a control of suppression of excess of hormone secretion in acromegaly, but it has been also recognized to be of certain utility in Cushing disease, because corticotropinomas are also expressing somatostatin receptor, and not just in general somatostatin receptor, but particularly somatostatin receptor 5. However, till now, the results we are having with the effects of pasireotide on the control of hormonal hypersecretion in corticotropinomas is not as good as we want. This slide just exemplifies the capacity, affinity of these two families of first generation and second generation somatostatin receptor ligands. And as you can see, as I said also, and this is interesting, and I will tell you some more in the next slides, pasireotide is also targeting somatostatin receptor 3. Somatostatin receptor 2 is, from this point of view, less potent than first generation somatostatin receptor ligands, but the affinity for receptor 5 is very strong, much more than octreotide and lanreotide. So, as I said, we have been living till now in a way that acromegaly was treated upon an assay error strategy. And as a consequence of that, virtually we have been, let's say, obligated to use these compounds, no matter how these patients were, and to see what would happen. And if it doesn't work, the guidelines till now have said, well, you might try another drug according to your clinical judgment or some phenotypic characteristics of the patient. But the drama is that when using first generation compounds, about 50% of our patients, if not less than 50%, do not respond adequately, because the patient remains either with a hypersecretion of somatostatin, of GH, or the effect on tumor volume, it is relevant. And this is only explained by the fact that acromegaly is not just clinically and radiologically heterogeneous, but also therapeutically heterogeneous. And all these heterogeneous characteristics from these different point of views or aspects are due to the fact that these tumors are biologically heterogeneous. We cannot believe that we are facing, when we are seeing an acromegalic patient, a single disease, but the disease are few or some. In either case, every patient might have a subtype of disease. And our obligation in the times currently and in the future will be to more deeply characterize these patients in order to assign the best treatment for them in a scenario in which we will be having more and more treatments for acromegaly. Could we predict what could be the response at the different treatments regarding the molecular information we can explore when a patient has received the first-line treatment, which is surgery? And mostly taking into account that the worst cases, those invasives, will not be cured by surgery because of the invasive characteristic nature of these tumors. But when we are having the tumor in our hands, we can go in deep and explore what the tumor is expressing, what are the molecules there. Because if certain molecules are not expressed, the treatments will not be active, we will not be having a positive response. Obviously, as you might imagine, if we have a tumor which has not been cured, the tumor is in our lab, we can look for what's the receptors expressed are there, because if there are no somatostatin receptors, we can forget the utilization of these compounds, even the second generation. We have some patients, young patients, with invasive, very active AP mutated cases in which we know that there will now be response to these compounds, and therefore we can split and we can not think to use this in a trial error approach. So in the last 15 years, we have had many, I have not listed the PubMed you can retrieve with the many molecules that have been included as single factors that might predict therapeutic response. And centered in somatostatin receptor family, those has been obviously one that started with research more than 20 years ago. This is one of the first publications, and in this case, in vitro and in vivo were compared by using immunohistochemistry. Immunohistochemistry is the more, till now, used technique in our clinical labs, in the pathology labs. They depend on the quality of the antibody we are using, but it is also operator dependent because it will depend on the judgment of the positivity according to the supervision of an expert pathologist. We are now moving to digitalization, which will standardize and homogenize the lecture of this immunohistochemistry, but still the quality of the antibody is very relevant. Some of us have been using not just immunohistochemistry, but also mRNA expression, gene expression, which is much easily to be quantitated, but we always having the argue from our colleagues, dear colleagues of the pathology labs, that we are not exploring the protein, but just the gene, and between the gene, the mRNA, and the protein, there could be some gaps that will not reflect what is really going on. In either case, you can see here that according to the intensity of the immunohistochemistry for somatostatin receptor 2, the percent of suppression of growth hormone in pituitary tissue and also in the clinicals is different, and obviously it's much more effective when the somatostatin receptor 2 is present and we are facing the response to octreotide or lanreotide. But I will also start to alert you, to warn you that, as you can see, the level of overlapping of patients in a responsive and non-responsive, it might be an important difficulty at the time of defining cutoff values for if we want to apply these measurements for the decision of using or not certain drugs. And this is one of the most important walls, most important problems we have been facing in the approach we are in the last years being using for trying to define biomarkers which will be useful for the utilization in what is now known as precision or personalized medicine. After these first studies, we also included, there were also included not just the measurement of somatostatin receptor 2, as it was clear that not just one receptor would explain the whole response to these drugs, but also the participation and no more, and even the relationship, the ratio between somatostatin receptor 2 and 5 would explain if a patient would be responsive or not. And as a matter of fact, about the same year, a group of Monica Gadela, and at this time Raul Luque was in the lab with Monica, were able to show that the ratio between receptor 2 and 5 of 1.3 was identifying those patients that would be responsive or not. But also, as I mentioned in the previous slide, you can see that we are still facing a gray zone in which there is no sufficient separation between groups and does not allow in those patients falling into this gray area what will be the responsiveness to therapeutic load with first generation somatostatin satellite. For biological and scientific description and going deep in the knowledge of these tumors and these somatostatin receptor families. This has been cardinal works, but the translation to clinical practice still a lot to do. And I would like also to mention here that in the deep research in the somatostatin receptor family, the Raúl Luque and Justo Castaño group in Córdoba discovered a new actor, which was somatostatin 5 transmembrane receptor 4, which is a truncated isoform of this somatostatin receptor, in which not 7, but just 5, and this is why it's called like this, of this receptor were expressed, and thus it was a aberrant receptor. And when this receptor is present, particularly in acromegalic patients, this was a very important predictor of non-responsiveness. It's meaning that in a patient in which this isoform, this truncated isoform is present, even you might have a paradoxical response and the utilization of these compounds may have as a consequence an increase in the tumor volume and non-control of hormonal hypersecretion. This receptor, as well as in general the somatostatin receptor family, is present not just obviously in somatotropinomas, as I mentioned, the corticotropinomas, but in the oncological world, they are present in many tumors, in prostate, in thyroid, where we have been able also to demonstrate that this transmembrane, the truncated receptor was present. And in all these cases, also in breast cancer, this truncated receptor is a marker of biological aggressiveness and non-responsiveness of most of the usual therapeutics used for these different tumors, not just referring to somatotropinomas, but also for breast cancer, prostate, and thyroid. So, going in deep to what is happening within the cell after the interaction of the ligand with the somatostatin receptor, it is very important that we will have a population of receptors that are expressed in the cells of the adenomas, because if the receptors are not there, forget, the treatment will not be effective. But you might have some apparently good expression of receptors in the surface of the adenoma cell, but if the pathway are not activated, you will not get a expected positive therapeutic response. So, not just for predicting, we have to know what's going on in the surface of the cell adenoma, but we will have to include to some extent, information regarding the molecules that drive the internal consequences, the pathways after the occupation of the receptor. And in this regard, in a fantastic work performed about more than 10 years ago by the group of Marta Corbonich, it was shown that even if the receptor was present, the absence of the pathway in which AIP and THAC as the next step were not active, the treatment was not effective. And they did in this experiment very elegant in vitro evaluation of the MRI after exposing to some concentration of octreotide. And when these cells that were responsive to this treatment were included a microRNA of interference, what was shown is that this responsiveness was stopped, meaning that the pathway is crucial, it should be active. And this is why we know now that those people dealing with or presenting familial isolated pituitary adenomas, no matter what is the phenotypic expression, either GH or ACTH, But when they are having AIP mutated, they are not responsive, or the response is very bad to first generation somatostatin receptor ligand. Meaning that if we want to predict, moreover, in individuals having pituitary adenomas and somatotropinomas at young ages, meaning less than 30 years, less than 25 years, we should include the evaluation of AIP mutation in order to not to lose time, because if they are mutated, probably we can predict that they will not be responsive to these compounds. So not just somatostatin receptors, and as I said, dopamine receptors, which collaborate, which showing mutual interactions, not just AIP and THAC, which connect somatostatin receptor 2, but other molecules have been, in the last decade, have been recognized as being predictors. Their measurement could predict individually what was the responsiveness to first generation somatostatin receptor ligand, those compounds that have been promoted to the first drugs to be used with what is not working, the surgery is not curative, of the patient does want to be operated, or will have a late surgical procedure for no matter the reason is. And at least about a dozen of these molecules have been declared of importance. But the question was, what would be the most important? What is the profile? What will be the molecules that we have to choose to make an, let's say, a reasonable predictive equation? So what we did in Spain is to collect samples from a huge cohort of the REMA initiative, which is a sort of biobank of different nodes of university hospitals all over Spain. And we were able to collect about 100 patients in which we have relevant information. Most of them didn't show predominant hypointensity of the MRI signal in T2, which is, by the way, one of the potential predictors of good responsiveness. And most of them were, let's say, bad guys. They were not be cured. And what we did here is to have a representative sample in which responsiveness was obtained by using octreotide or lanreotide, or was not obtained according to an AGF-1 after 9-12 months of treatment, which was 3 standard deviation of the normal limits, are in between condition. And as you can see, we clearly saw, as we knew, as we were expecting to find, that biologically somatotropinomas are very heterogeneous. There is no clustering of these potentially individual predictors for aggregating, for subclassifying different subtypes. When we saw that, we fall obviously not in depression, but we had, as it was said years ago, Houston, we had a problem here, because we had molecules which individually might work, but we saw, well, if we put all together, we might have a combination of them that will work. And this was not the case. But when we examine again the potential more important receptor, which was somatostatin receptor 2, yes, the expression statistically indicated that obviously, previously published, somatostatin receptor 2 high expression was more predicting that those cases that were not responsiveness. And there were also some group in between, and the extreme groups were really significantly statistically different. But clinically, we had a problem, because as you can see here, yes, the means are different, but the standard deviation are so high that the overlapping not allows us to have a cutoff point. However, the receiving operator curve, which is what we use for evaluating the predictiveness of a biomarker, was 0.65, 1.65, which is an humble result. This is a very, let's say, I wouldn't say poor, but not very good result. And at our surprise, icatharin presented at much higher under the curve. And in fact, icatharin was also able, from the statistical point of view, to differentiate those partial responders with potential candidates of a combined treatment with octreotide and pevesomant, for example, or going through pasireotide. But again, the issue of the overlapping was a major problem, And not just that, but when we combined both icatharin, which was not surprisingly, but higher than somatostatin receptor 2, we got a area under the curve which was not much better than per separate of each candidate. This was so because when we perform a Spearman correlation matrix, what we can see is that somatostatin receptor 2 and icatharin show the best correlation, Spearman correlation, when you compare with the other individual markers previously recognized as biomarkers of response to somatostatin receptor ligands of first generation. So we still have a problem here. Why icatharin? Why am I moving from somatostatin receptors to icatharin? Why? Because icatharin seems to be much more useful, and it's a picture, a better picture of what it is, a somatotropic cell much near to the naturally occurring somatotropic cell in non-pituitary tumors. The cells are much more in anatomical contact, in the icatharin in this regard exemplifies and recognizes this kind of phenotype, which is less invasive in obviously probably is indicating that the family of somatostatin receptors in general, but particularly receptor 2, will be more present in this tumor. And to try to define a cutoff point, probably it was much useful than the somatostatin receptor 2 itself. We saw this, and other also show that obviously the invasiveness, meaning the bad guys, the bad somatotropinomas, are present when icatharin is not there or is very lowly expressed, because the attachment of cell to cell in the adenoma disappears, and those tumors express the bad brother of icatharin, which is encatharin. Also vimentin and SMAD4, which is also involved in the epithelial mesenchymal transition genes, which are overexpressed in invasive tumors. And when we explore the icatharin pathway, which is driven by this transcription factor, which is ROR, you can see here with the complete response, partial response, or non-response, that there is a clear dose-dependent curve, which is also showing this overlapping, but which is having an area under the curve which is much more attractive, with 80.8 area under the curve. It's much better than 0.7. We have gained a little bit more. This feel as a clinician more confidence when we have to rely on this kind of biomarker rather than even icatharin itself. And the contrary, the contra-ROR transcription factor, which we SNEL, is having a mirror image with non-responsiveness much more expressed by SNEL, this transcription factor, which behaves the opposite of ROR. What about the predictiveness when we explore somatostatin receptors families in those patients not responsiveness to octreotide or lanreotide? Then we look for pasireotide biomarkers. We still have many work to do, a lot of work to do. We are doing in our lab in collaboration with the rest of Spanish hospitals participating in the RIMA initiative. But you can see here in a nice work, preliminary, already 9 years ago, in collaboration from the Gemelli group, Professor Laura de Marinis with the lab of Marta Corbonis, that obviously if pasireotide targets somatostatin receptor 5, if we look at the immunohistochemistry of receptor 5, the score, the immunohistochemical score, will obviously recognize those subjects that individually will be responsive to pasireotide. But as you can see here, also these tumors more aggressive, which have not been able to be cured, still just show a 60% overall response to pasireotide, meaning that we still have to identify why a patient under pasireotide is not responsive. And this is not just explained by a high score of somatostatin receptor 5. However, interestingly, as I mentioned, that AIP mutation, or in this case, not just the mutation, but the expression of the protein, it's as important in non-mutated AIP if the AIP is expressed in a significant way or not. And the immunohistochemistry for AIP is also interesting because the responsiveness with pasireotide is seen independently of AIP, meaning that AIP might be important for somatostatin receptor 2 pathway, but somatostatin receptor 5 is much more independent of AIP protein expression within the cell. I just want to mention one more thing regarding pasireotide and somatostatin receptor, and I just want to focus you here. As I said, here what we did is to collect 81 patients treated with pasireotide, and what we're looking to see if hyperintensity signaling T2 was an identifier of responsiveness to pasireotide. The answer was yes. But more important thing is that when these patients were treated, the antiproliferative effect or the tumor burden reduction was very much important when these patients were treated with pasireotide. And we go again to focus on somatostatin receptor 3, when in the first slide in my presentation, I show you that obviously this will be a very important target. And as a matter of fact, also again, the lab of our friends in Córdoba, in vitro studies, delineated or designed a new compound in which the target was specifically devoted to connect or to bind only somatostatin receptor 3. Pasireotide, as I presented previously, has an affinity which is quite remarkable compared to the compounds of first generation. As you can see here, when you target somatostatin receptor 3, the proliferative capacity of in vitro culture of pituitary adenomas is clearly inhibited. And that could explain that in some cases in which residual tumor after acromegaly of pituitary surgery was performed, but residual, not accessible, was treated for some time, the tumor virtually disappeared, and the patient in this case report by the Gemelli group fall into a cure or reversal of active acromegaly, which is a very important point to take into account in our armamentarium in these such a cases where we still have this is the active because we have a residue which is in the vicinity of the carotid siphon, and obviously the cavernous sinus is a very difficult way to enter and to remove the tumoral residue. So it's clear that the usefulness of different molecules, including somatostatin receptor, is very relevant, but not just the answer is to explore somatostatin receptor. We need more information in a tumor which has not been able to be cured by surgery, and we might need to incorporate probably AIP, and why not the proliferative index KC67. And obviously we will have two different extreme phenotypes in which high receptor 2 high E-cadherin, low somatostatin receptor 5, high AIP will in one side and the contrary in the other. But what in those that are in the middle? So this is the problem when we want to make or we want to perform precision medicine. And we, after all the studies we performed, looking at that E-cadherin was very relevant, we set up 4 years ago a study which, as a matter of fact, followed into the pandemic, but we were able to finish it, in which we included 81 patients of real life in a clinical ESE, in where we combined the personalized treatment in which only first generation somatostatin ligands or pegvisomant or the combination were used. We included MRI imaging, acute octreotide test, and in those patients not cured, just E-cadherin itself, the immunohistochemistry of E-cadherin. And as you can see here, in 9-month, 12-month follow-up, those patients which were the treatment decided according to these biomarkers achieve 80% compared to just 20% of non-responsiveness, while, as expected, the group of the standard protocol, usual, you start with somatostatin receptor ligand first generation, achieve only 50% of control. And more importantly, those in the personalized group achieve hormonal control at much faster period of time. In about 6 months, the 80% was already there under control. So just with E-cadherin and some imaging and functional biomarkers, we were able to set up personalized medicine. And E-cadherin as a reflectiveness of what was going on with somatostatin receptor, because the treatment we use here included obviously first generation somatostatin receptor ligands. But we have to go on, and thereafter we have to remind that there is not just a matter of 1 or 2 or 3 molecules. We are now knowing that the biology is explained by the interaction of all the molecules, and the thousands of molecules that interact themselves could be now analyzed through artificial intelligence. And this would probably allow to dissect much betterly the heterogeneous condition of acromegaly disease, in which we can use as many as biomarkers we might or we want to introduce in the formula. These could select what will be the treatment through different procedures in which data mining and bioinformaticians are the guys that should have to make the travel with us for treating these patients. So how we can build out, how we can build a cutoff values when the classical research show these results. So what we do here by using artificial intelligence and particularly data mining is to combine 2, 3, or 4, or even 5 different markers that could express from a quantitative point of view at different levels. But that combination of all this is what will really show you what will be the cutoff values. And if till now you have been accustomed to see a cutoff value that separate with a line 2 groups, now we are facing what it's called functional or dynamic cutoff values, in which for a given patient a cutoff value could be different than for another patient. And this is with an equation that which is obtained by data mining. This could be obtained. Here you have another example. You can see here that the cutoff line is not a rectilinear line, but is a curve, is a sigmoid curve. It was hard to me to understand that, but it's obviously that the combination of different values of these different markers might show in a given patient different results, but the analysis with the known cohort of the responsiveness to treatment will show us. And in this way, we were able, with combining the 13 genes with a panel of about 5, a algorithm of prediction taking into account relevant clinical feature, as if the patient is having invasiveness through the cavernous sinus. And here is depicted complete response, partial or no response, and measuring this different, the expression, the mRNA level of these different molecules. You can see here what is the level of accuracy we are able to see with this panel of markers. It is not 100%, but it's better than the 50%, which is the same that if you have a coin and you throw it in the air and you can see the patient, okay, we are doing this treatment of this other. And also, you know that the responsiveness is not the same in male and female. And with this algorithm, we were also able to make a prediction at about 80% level of accuracy. But it is evident that if we are not reaching the 100% of accuracy, this means that there are no all the biomarkers in the formula. And this is why what we have applied in the last times is an approach by using our biobank, in which we perform massive RNA sequencing, and we also included with an analysis by using artificial intelligence, and we explore 22,000 genes, in which we saw that about more than almost 900 genes were differentially expressed when treated with first generation somatostatin receptor ligand. And here, yes, we were able to get some clustering of the results. You may remember the first heat map that I showed you, that we were unable to classify these patients. Now with this approach, we have been able, but identifying new biomarkers. Not just that, but with just 2 pairs of molecules, we were able to reach about 100% accuracy to predict the responsiveness of somatostatin receptor ligand first generation. And obviously, somatostatin receptor 2 is within one of these pairs. And these pairs, which are now under validation in our lab, because we have lasted a long time to retrieve another 100 patients series, which is almost a little bit short, but you can see that all these molecules that are referred here are mainly of the family of proteins which participate in molecular, in secretory granules, So, to end, this is the beginning of precision medicine, in which molecular information, which will be able to predict what will be the behavior of the tumor, the responsiveness to a given treatment will be necessary, because with the new treatments we will be having, it will be very difficult to decide which will be the one to be used, unless we want to not to lose time and money and use biomarkers for our medicine of not the future, for the present. And with this, I close my presentation. I think that we still have 5 to 10 minutes for discussion. This is where I am, Badalona. It is no Barcelona. This is the Barcelona city, and this is the area of No Barcelona in our campus, Can Ruti, where we are working in the Research Institute, in the Faculty of Medicine, and in the Hospital Germans Trias. This is my service in part of our research lab. Thank you very much for your attention. I'm ready for the questions.
Thank you, Professor, for this excellent talk. I think that all participants, including myself, we were really lucky to listen to this lecture, very comprehensive and with the view into the future, really. I was very impressed. So, for the participants, you can ask questions in the Q&A part, or you can turn on your camera and microphones and ask questions. We have this opportunity to learn from Professor, so don't hesitate to take this great opportunity. Or you can even write your questions.
After this talk, I presume that they should be sleeping more.
No, it was really interesting. So, until we have some questions from the participants, if you were in a poor country that not the system cannot cover the costs for all these good markers, which one or two would you choose in order to have a personalized approach in the best way possible?
Without no doubt, from the molecular point of view, the combination of icatherine, which is in every pathological lab because it is used for many oncological diagnosis, characterization of tumors, and somatostatin receptor 2, which obviously we are endocrinologists, but as you know, somatostatin receptor is also expressed, for example, in many brain tumors, meningioma, meningoblastoma, and obviously could be the target of this compound. In our hospital, our pathologists have been convinced that these molecules, not just icatherine, which was already there, but somatostatin receptor 2 could be used. The question is which will be the antibody, what will be the cutoff points for immunohistochemistry, but this is already there. And we as endocrinology could take advantage of something which is, I would say, standard pathological clinical diagnosis. Use it. And also, before surgery, when you still not have the sample of the tumor, look at the signal, the T2 signal of the somatotropinoma, and definitely use the short acute octreotide test, very easily to perform. And the whole set of things that I am now giving you as an answer do not cost in standard country like Spain more than probably 40 euros, right? The test is there. The image should be performed. It is a matter that the radiologist, the neuroradiologist give you the information. You might even learn how to identify hyper or hypointensity. And icatherine and somatostatin receptor 2 is inexpensive, I would say. This is the combination.
I was really impressed by the diagram you showed that with the use of Caterin, it changed the outcomes in a statistically significant way. This is really amazing. I think it was the JCM paper, if I'm not wrong. Okay, people, congratulate and thank you for the excellent talk. And so I cannot see that there are questions. Is there anybody that want to ask something urgent? Because I think it's also it's 7 o'clock. So
Well, this is good for me because I'm not challenged by hard questions.
you covered everything. It was so detailed that I think that no questions remained unanswered. So, okay. So we would really like to thank Professor Manel for this excellent talk. I would like to thank again on behalf of the European Society for Endocrinology, the European Neuroendocrine Association for the collaboration today. I would like to remind also to all of you that today is the first World Hormone Day, and we should take advantage of that and inform communities and scientific societies about hormones and endocrine conditions. It's a very interesting month, May. We have the ECE, the European Congress of Endocrinology in Copenhagen. I hope that we will meet all there. Other very important events are also happening. We have the ESE Summer School. For early career people, you can check and apply for the summer school. We have a great series of ESE talks that have to do with nurses, scientists. Really many things are going on. Regarding the next ESE Spotlight on Science, it will be on Thursday, 19th of June, and we will discuss with very important speakers and experts in the field about the advances in the etiopathiology of polycystic ovary syndrome, which is a very common condition. It affects a large percentage of women of reproductive age. And I think talking about etiopathiology, it would be very interesting both of a clinical and a research point of view. With all this information, I would like to close this session today, and I wish you all a great evening. Thank you very much.
Thank you, Lina. Thank you, all the ESE team, and thank you for your attention. And good Hormone Day. Bye.
Bye.